I'm Dr. Diamond. I work at the University of Miami. I do a lot of different things, actually. I'm kind of what we call a translational person, where I see patients in clinic 1 day a week, and the rest of the time I dedicate to trying to understand the disease. I do a lot of research, primarily in genomics, and trying to understand what makes this disease tick. So we only have 20 minutes right now for this particular session, and originally I was going to talk a little bit about options in relapsed refractory multiple myeloma, but you're all here and you have this chance to ask questions, and I think we should capitalize on that. So within the realm of some of the new treatments that we're developing, the bispecific antibodies, the CAR T-cell therapies that you heard both Drs. Green and Dr. Coffey talk about earlier today, I'd like to be able to be a source for you guys right now to see if I can answer any of the questions that you might have had from their talks or questions that you might have about therapies that are on the horizon. So please do not be shy. We have a microphone that's going to be circulating around. Let's start.
I want to know what your thoughts are with CAR T being available after the first line of therapy, and how quickly, based on the recent FDA decision, is that going to be available? Because obviously they just made the decision, it's going to take a little while. How long before, if my myeloma is progressing, that I'll be able to access this after the first line of therapy?
So great question, thank you for asking it. So as you guys have been following the news, we have this recent recommendation for both cilta-cel and ide-cel, the CAR T therapies, to move up into the earlier lines of treatment. The question is, does every single patient need to get the therapy this early on? The truth is, we don't really know. The data looks fantastic, and that's the reason that the ODAC has recommended that these therapies move up. But right now, we're in the phase where we have the recommendation to move forward. We just don't know exactly how soon this is going to be available for patients. There are multiple things that go into this decision, right? So the FDA can go ahead and they can approve it, but we have to also make sure that the drug companies are going to be able to scale up their manufacturing and that the institutions are going to be able to meet the needs of all of these extra slots that are going to become available, or that are going to need to become available to meet those needs. So I don't have a crystal ball to be able to tell you for every individual situation when that's going to be, but at the rate that things are going, it's going to be quite soon. The next question is going to be, as these therapies become available to everybody, the next question is going to be, well, are they going to be available in the frontline setting, in the newly diagnosed setting? And I think as things move forward, we really have to be careful about who we decide gets what therapy so that we manage the resources and also the risk of everyone's individual disease, right? We have to balance the efficacy of these therapies, which is fantastic, but also the side effects, and make sure that everybody gets the therapy that they need.
I have a question. It said bispecifics, and you are on them until disease progression. What about if you become MRD negative during that time? Do you stop, or do you continue on them?
So this is a really fantastic question. Again, thank you for asking it. The short answer is we do not know, okay? And those are things that we're going to have to be looking at. I can give you some anecdotal experience that even though these drugs were initially approved to be given continuously, the majority of people that are giving these drugs are now starting to de-escalate that much, much faster. A lot of people are starting to de-escalate at first signs of response, right? Once a really good response is achieved, do we really need to keep hammering this with weekly or every other weekly therapy? And a lot of my patients are on monthly dosing at this point. The question as to how long you really have to continue this is something that we do not know. I mean, if somebody's MRD negative, which many patients are, do they really need to stay on it? How often do they need to get it? Multiple studies are examining this. And I can give you an anecdote where one of my patients is on one of these drugs. They still have measurable disease. They had terrible toxicity after, I think, 3 doses. We made it through 3. And it is now at least 8 months later. There's still disease measurable, but it is not moving. It has not changed. It's still there, but it's stable. And these are the kind of immune responses that we are currently really, really, really needing to understand, because if we can recapitulate that for everybody, wouldn't that be great?
Yes, I have several questions, but I'll stop at 2. First, I know that early identification is key for everything, but how can a patient ask her primary physician to look for the blood results, that the protein results that may result into multiple myeloma?
So you've asked a very challenging question, because I don't know how everybody's going to react to this out in the community. As you know, really, there is no real recommended screening strategy for this disease. We consider it to be common, right? It's the second most common hematologic malignancy, but in the grand scheme of things, it's relatively rare, and there's never been a proven benefit to screening early for this. We can look to our colleagues over in Iceland who are doing the iStop-MM study, and they're screening the entire population. They are finding a benefit, but that's a very homogeneous single country's population. It's not like the United States. So the short answer is that if you are worried about this, you have some reason that you're extra worried about this and you want to be screened for it, you can always ask your primary care doctor. I mean, the tests are relatively simple. All right, they just have to send the usual myeloma studies, which is the serum protein electrophoresis and the free light chains. If those come back abnormal, then they can refer you further to speak to a specialist to see what else might need to be done or not done.
May I ask one more question? Why is it at stage 4 or a late stage before one finds out about having multiple myeloma?
Also sort of a really good question, right? So the question is about staging and how we identify this disease and sometimes identify it late. And so as we talked about, there's no real screening mechanism for this disease. And so I hesitate to use the word stage in multiple myeloma. We think about staging a lot in solid tumors, right? These are solid malignancies that start in one spot, and as they progress through the stages, they spread throughout the body. That's not multiple myeloma, which is a blood cancer, and by definition, it's in the blood, it's everywhere. And so stage to me matters a little bit less, and the current staging systems in multiple myeloma are based on some markers that are a little bit less relevant to this day. I think the question is more, when people present, how do we stop them from presenting with more advanced disease? This is a tricky thing. We don't know. There are the unlucky people that will present in the first place. They basically step off the curve and have a fracture in their back, or unbeknownst to them, they have some kidney failure and things are getting worse. These are things that you just need to really be plugged into your primary care doctor to make sure that you're following along with your annual health. If they see any changes in your kidney function, or if they see any changes in maybe your bone density, for example, these are things that need to be picked up on. But apart from that, picking up those early cases is a little bit challenging for the reasons that we discussed.
See, I've had high-risk myeloma for 8 years. I'm now on my 5th. I'm teclistamab, and I have 25% kidney function. And I guess earlier the gentleman said the CAR-T, maybe I wouldn't be eligible for that with low kidney function. I just wondered what would be my next option.
Absolutely, and thanks for sharing your story. There are lots of options, actually. So if you've been on one bispecific antibody, there are other targets. All right. So I think you just said teclistamab, right, which is a BCMA-directed antibody. There is already approval for a GPRC5D, it's just another cell surface antigen. The way to think about it, as we talked earlier in Dr. Coffey's session, is that if you have an immune strategy and you want to get your immune system to attack these cells, you just have to find a target that's on the surface of the myeloma cell that's not really on any of the other cells in the body, right? That helps you maximize the specificity of your drug while minimizing the toxicity. I don't want my drug to attack your healthy cells. I want it to focus on the myeloma cells. And with that strategy, there's already another target. It's a protein called GPRC5D that's approved. It's a Janssen product. There are multiple other BCMA products, which some research is showing that, even if you relapse on teclistamab, you might be sensitive to another BCMA-directed product. There's a GPRC5D. There's another drug called an FcRH5 inhibitor. And moving forward, there's going to be even more and more targets. So this is a strategy that's here to stay, and we're very, in the very early phases of it. There's going to be other drugs, and even if not CAR-T, plenty of other immune strategies.
Seems, as I look at a lot of the slides where they look at response based on M protein, what if your M protein's always been negative and you're a light chain? I don't necessarily see that as one of the data points in some of the studies.
So good question. The question here is, when we're looking at the slides, we see a lot of talk about M protein and less about free light chains. The reason for that is that I think M protein is a little bit more easy to conceptualize. But I promise you, on these studies, they are looking into free light chain myeloma, which is about 20% of myeloma, and it's part of the response criteria. So if you have free light chain myeloma, there's still a way to quantify, your very good partial response, your complete response, and your MRD negativity. And having free light chain myeloma does not mean that the disease is any worse. It's just a different way to measure it. So when we talk about these responses, they're all rolled in together.
Hi. I had a question regarding MRD negative. If you're being diagnosed with that, at what point, if you relapse, if they do deep testing to the -3 or 6, what is considered a relapse in MRD positive? Is it just 1 cell or is it 20 cells? And at what point do you start treatment again?
Great question. It's very philosophical.
Okay.
The trick is that we use MRD now prognostically, and we know it's extremely important. We know that when people reach those extremely deep remissions, 10 to the -5, or 1 in 100,000 cells is the currently sort of approved goal. But we're going down to 1 in a million, and then even out of Chicago, they're down to 1 in 10 million now. This is 10 to the -7. And they do that basically by hyper-concentrating the bone marrow to look only at the plasma cells and then doing the MRD test on those. So we're going to go deeper and deeper and deeper. We don't know yet what it means if some of the cells start to come back. In a study that we did all together at Sloan Kettering, looking at people that were on maintenance therapy on lenalidomide who were MRD negative, what we saw it was a relatively small group, it was 108 patients, but what we did see was that as people started to convert from negativity to positivity, invariably a relapse followed, okay? And that relapse would happen within maybe 12 months to 18 months, right? So this is an early sign. The question of whether to intervene at that point that you start to see the MRD positivity come back versus waiting for the M protein to come back versus waiting till there's anything else like an imaging finding or disease, that's a continuum that we don't know where we need to intervene. Obviously, we want to intervene before something bad happens, but whether we need to interrupt your good life when you're on maintenance and just have an MRD switch, if we could alter the disease biology by intervening early and changing the course of things, obviously we would do it. But we don't know if that's really the case right now. And so currently, as far as I know, there's no studies that are really examining exactly what to do at that point of conversion.
Okay, so would the M-spike show, if your MRD went to like 20 cells, would your M-spike show anything or not necessarily?
Probably not.
Not, okay.
No.
Okay, thank
Because we're still talking, 20 cells is basically the limit. You need at least 20 cells to have a confident call in most cases. And so that would be looking at basically like the lowest limit of MRD positivity you could possibly reach.
Is there any definite connection between family members with myeloma? For instance, I have multiple myeloma, and our son was diagnosed with MGUS. I saw in your bio that you treat patients with MGUS, so I'm interested to know if there's a direct connection or not.
So great question. I will start off by making the distinction that I see people with MGUS, but I don't treat people with MGUS. None of us really do, and I think for the better. We don't want to treat people that are healthy and are basically at the lowest risk of progression. But to the question of whether or not there's a risk among families, there definitely is. It's a much more complicated question than it is for something like breast cancer, where you have the BRCA gene, and if you have that gene, there's a very high risk of developing the breast cancer. It's not really like that in myeloma, and part of the reason is that this is a cancer of the immune system, and so there's multiple different factors that play a role. So there can be very small heritable factors, genetic features that make it a little bit more likely to develop the disease, but then you also have to understand that because it's an immune system cancer, a lot of experiences that are shared, a lot of exposures, things that, infections that you had as a child or exposures to certain chemicals that we don't know, those experiences are often shared between family members as well. So, if you grow up in the same household, right, you have a lot of the same exposures. And so trying to tease out which are due to genetic features and which are due to exposures is very difficult. Suffice it to say that we do see that there's a very small increased risk for people with family members to develop multiple myeloma. There's been certain little, we call them polymorphisms, which are not mutations necessarily, but just normal variation in the genome. So your genetics can govern a little bit of the likelihood for developing some of these immune issues. But we don't know exactly which ones they are and how important each of those specific polymorphisms is. The short answer that we usually tell people is that there is about a double risk, relative risk, for family members to develop multiple myeloma, but the absolute risk is very small. So making up a number, if your relative risk of developing multiple myeloma is 0.1% over the lifetime, then a family member is 0.2%. When we double that relative risk, the absolute risk becomes 0.2.
What's the current state of stem cell transplantation? Are stem cells being, is that still seen as a good cure or, cure with quotes around it?
So great question. So the question's about, where stem cell transplantation and high-dose melphalan sits currently in our treatment paradigms. So stem cell transplant is a very tried and true therapy. It works. The way I like to think about it is that when we're giving it in the upfront setting, you get your combination therapy, which is now 4 drugs. And if I need to deepen that response, well, then I add melphalan. That's the 5th drug. Okay, so of course, when I add 5 drugs instead of 4, people are going to do better. The question about where it stands in relation to some of the newer therapies is currently an unknown. There's like an EMN trial, for example, where they're actually comparing CAR T cells to transplant as consolidation to try and figure out if maybe doing CAR T cells instead of an autologous transplant is a good strategy. We don't have anything like that currently in the States, although we'd like to investigate. So the short answer is we don't know. There's a lot of data that suggests that for transplant, again, great therapy, but not everybody needs to do it up front. And so trying to figure out who the people that should do it or shouldn't do it is really a huge area of active research. We're working on that, and I will talk a little bit about that later in the talk. But we, for everybody, regardless of whether they want to pursue the therapy up front or not, should try to collect their stem cells, because that way you have your stem cells banked in the freezer, and if you want to use them for a transplant, they last for 30 years in the freezer. And even if you don't use them for a transplant, there are other things you can do with those stem cells. So for example, with the CAR T cell therapies, people can sometimes develop very prolonged cytopenias, we say low blood counts, and you can actually use the stem cells as a boost to help get over that side effect. So if you have the option to collect those stem cells, collect them, because they're a really good insurance policy to have.
I was just curious, with the CAR T cell, in the other room, they were showing that somebody that had a relapse, that the survival rate after that was only lasted about 11 months or something like that. Does it depend on when you get the CAR T, how long you stay in remission? Like if you get it as a 3rd line versus an 8th line, what's the difference as far as how long you stay in remission?
Great question, and that is really the reason that they're talking about bringing the drugs closer into the frontline setting. So the short answer is yes. If you get it earlier, you have a longer response, and that's kind of the case with all drugs. As the disease is less resistant overall, is less aggressive, has less genetic features that make it high risk, the treatments are going to work better. What we've seen, though, is even though the responses are better, it doesn't change the fact that people will invariably have a relapse with these therapies. So that's kind of the rationale for trying to figure out really who needs to go through the procedure, right? If I know I can't cure the disease with this, I know it does work better, but I can't cure it, then does everybody need to get it, right at the beginning versus, at certain points in their treatment journey?
We have time for 1 or 2 more questions.
Thank you. I'm 4 months into remission after 1 year of induction.
Congrats.
And things are going great, but when do I push for MRD testing?
So this is a good question about timing of MRD. When do we test it? And the question is really what question you're trying to answer with the MRD test. So if we're trying to figure out how good your induction therapy was, how good your initial response was, we usually will say, you should do it basically at the end of your induction, right? So if you had 6 or 8 months of induction therapy, plus or minus the transplant, do it right then and there, right? You want to know before you de-escalate.
I'm not transplant eligible.
Either way, after your induction therapy, including plus or minus the transplant. When you're done, basically, before you kind of de-escalate the therapy and go on to maintenance, right? Before I pull back and decrease the amount of therapy I'm going to get, I want to know where the disease stands before I move forward. So usually that's how we'll do it. At the end of the induction, transplant or no, we do the PET scan, we do the MRD testing with the bone marrow, and that tells us where we are before we pull back. The question about whether or not to keep doing MRD testing is sort of individualized, right? I think if people want more information, you can maybe do it on a yearly basis. But if that information is not going to change the way you do things, then maybe you don't need to do it. For example, there are people that are doing just fine on their maintenance therapy and they don't want to change anything. And so if I have MRD testing that says they're negative or positive, it doesn't really change what we do. But if you have a person that's kind of not really loving the maintenance therapy, that for them it's very toxic, it's causing fatigue, they're getting diarrhea,
I'm very comfortable with it.
but you could imagine a situation.
So I'm imagining, when do I have to push her to, or should I?
So if you're very, I mean, again, it's a question for the individual, right? So if you're comfortable on your maintenance therapy and you don't want to change anything, then the MRD test just offers you more information. But for somebody that's wanting to consider changing their therapy, to potentially consider pulling back even on the maintenance therapy, having extra data points for the MRD negativity will make that decision a little bit easier. If you're MRD negative for 2 years, 3 years, there's already plenty of data that shows that these are the people to do exceptionally well, and the added benefit of continuing maintenance therapy often doesn't outweigh the side effects. So for somebody like that, I think that's a really good reason to pursue the MRD testing. If you're not going to change anything at all, and you're super happy with the way things are, you may not need to go through the extra procedure, and you can wait for some of the easier MRD tests to come out, the peripheral blood testing that's going to be less invasive, for example, and that's already on the horizon.
Yeah, compared to induction, this is fantastic. Just one more, about screening pre. People have AGG testing and light chain testing. What else should they have done if they have a sneaky suspicion something's going on? If their AGG's off the walls but their light chains are okay, is there something else that can help them?
Yeah, so you put me in a little bit of a challenging position because now we're talking a little bit more broad, and it's like, maybe it's not myeloma, but if there's some lab abnormality that's going on, you might want to investigate that further because something is abnormal. I would just say this, is that if there's a suspicion or a desire to test for myeloma, there's a recognized set of labs that you would want to test for. And really the thing that you want to look for is proving that there's a monoclonal protein, right? Because that's what you need for the diagnosis. So that's the electrophoresis. And if you have, if you're one of the 20% of people that has a light chain disease, then it's the free light chains and looking for an imbalance in one light chain versus the other. So with those tests, you can get to a very high, you might miss some of the people that have non-secretory myeloma. That is much rarer. For the majority of people, that's going to capture what you want to know. Sure, yeah. Everybody's got a little bit of a different flavor, but yes.
All right. We'll do one more.
Does diet play a role in remediation?
This is the million-dollar question. I'll tell you right off the bat that there's no definitive data that says that diet really controls how the disease behaves. There's a lot of data coming out of MSK, for example, with Urvi Shah. She actually looked, I talked to you about the maintenance study with 108 patients. From that trial, a wealth of data is being ascertained. So looking at those patients that were MRD negative, was there something that they were doing that helped to augment that? And it looks like, at least preliminarily, there are some dietary changes that some of the patients had made that helped them. But it's hard to, again, with dietary studies, because everybody's situation is different, and how do you really define diet? It's really tough. I will say in general that people that eat healthy, whole foods, plant-based diets with less processed food, less refined foods, tend to do better over the long term. I can't promise that's because these people aren't more well-resourced and have better access to different health technologies versus people that can't keep those diets. But we do see that people that keep those healthy diets in general and work and exercise have better outcomes over the long term. That's because if something bad ever is to happen, they're much more fit, their bodies are more healthy, their immune systems are better, to the point where they can roll with the punches better. And any therapies that they need to take, any treatments that they need to go through are going to be much better tolerated and potentially even better in those patients.
I'm sorry. How about exercise, physical therapy, as it relates to the outcome?
100% agree, and to the same point as the diet, we want everybody to stay active and to stay healthy because that increases your fitness. Your metabolic health is extremely important, and even for people that have active disease, they have pain from the disease, we try and find ways for them to stay active. And again, keeping fit is a way to keep your body rolling with the punches. You can tolerate other things, and it keeps your immune system nice and healthy. So we really advocate hard for proper diet and exercise.